Nina Yamanis. I'm an assistant professor at American University, and I completed my doctoral studies here at UNC and my postdoc at Duke in the Global Health Institute, where I was mentored in part by Jim Moody, and where I first took a class on social networks and health. So it is kind of coming back home, which is wonderful. And this work is in collaboration with Brian Aronson, who's a PhD candidate in sociology at Duke and also part of the DNAC group. So my talk is really about HIV testing among men in sub-Saharan Africa. So for some of you who may not be familiar with this area of work, I just wanted to point out that men have historically low rates of HIV testing in Africa, somewhere between 30 and 60% across several countries in sub-Saharan Africa. And the consequences of that include premature mortality to men and also ongoing HIV transmission to women, which, as you may or may not know, women have 2 to 3 times higher HIV prevalence rates in sub-Saharan Africa compared to men. And so our interest in HIV testing is really linked both to men's premature mortality, but also to transmission to women. And men's testing is also linked to the success of other kinds of HIV interventions, like prevention of maternal-to-child transmission. And what I'm talking about today is really about how social networks influence men's testing. So just to throw a little theory in there, the theory of social influence, as we know, postulates that individuals adopt behaviors they perceive as normative within their networks in order to reinforce their sense of belonging and identity to a group. And I'm going to tell you a little bit about the groups that we have of men in Tanzania. Some of you may remember there was another talk on this topic last year with Martin Lulawa, who was also a postdoc here at Duke. And we know from a number of studies in the US and also in Latin America that peer norms are particularly influential for men's sexual risk behaviors, including HIV testing, and increased in condom use, early sexual debut, number of sexual partners, and in work I did with Jim, having concurrent sexual partners in this context. So the study purpose was to understand how social networks influence changes in HIV testing behavior during an HIV prevention trial with young Tanzanian men. My dissertation work uncovered these social networks of men that they call actually locally camps. And camps are really amazing kind of closed social networks. They are pretty stable. When we did this first data collection, they had existed for an average of 8 years. They had a roster with all their members listed on it. They had elected leaders. They still have, including a chair, a secretary, and a treasurer. They have an average of 32 members, most of whom are male. And they meet in these kind of fixed social locations. This is a slum area of Dar es Salaam, so they kind of claim a public space for themselves and meet there every day, really. And we showed in other papers that they have both risk and protective features for HIV. The risk features are things like meeting new sexual partners, meeting sex workers at the camps. The protective features are things like supporting each other socially and through economic support to have employment, to take care of family issues. And here's one camp. This is Al-Qaeda camp. Not affiliated with Al-Qaeda itself. But men in camps kind of choose names for themselves, and these names are all things like powerful and brave and bold, and Al-Qaeda is just a name that they know is a powerful name, so that's why they chose it. My hand is on Bundala, who's the chairman, Tom Poe, who's the secretary. They give themselves nicknames, so it makes it easy to identify them because everybody knows them by that nickname, because many names in Tanzania, as most Muslim African countries, are kind of similar, like Ali, Hassan, or Mohammed. So these nicknames help us give unique identifiers for the men. And this is part of a microfinance and health intervention that was funded by NIMH. And the aim of this entire intervention, which is not necessarily important to this talk, but you should just know, is to determine whether men in camps who are randomized to a microfinance and health intervention had a lower incidence of sexually transmitted infections and reported perpetrating less intimate partner violence compared to men in control camps. And the mediators of this intervention trial included HIV testing. But I wanted to give you some sense of the data. So it's a cluster randomized control trial with 59 camps. 1,249 men and 242 women. And the protocol for the trial is published in BMC Public Health. So we actually used 4 wards, and we identified 205 eligible camps. So these are closed social networks across these 4 wards. That we had a number of criteria for the networks. They had to exist for at least 1 year. They had to have between 20 and 80 members. They had to be safe for our interviewers. We had a few camps where a weapon had been used in a fight in the past few months, and we didn't want our interviewers necessarily going there. And then we actually clustered the camps geographically and then chose these clusters randomly so that we wouldn't have any contamination amongst camps. So only 1 camp within the cluster was selected for the trial. But that was important so that we didn't have 2 camps next to each other that were, one was in the intervention, one was in the control, because there would certainly be room for contamination there. And so we selected a simple random sample of 60 camps. 1 camp ended up being a fake, so we ended up with 59 camps. So all camp members received assessments at 3 waves, and these were on tablets that were computer-assisted personal interviews. They got both behavioral and social network assessments. And the 3 waves were at baseline, so the start of the intervention, at midline, 12 months into the intervention, and at endline, which was 30 months. We also did biological assessments, and the dependent variable for this work I'm going to present today is, have you tested for HIV in the past 12 months? In terms of the social network data, we gave them a camp roster. Every single person in the camp who completed the survey saw a whole roster of all their camp members with the first name, last name, nickname, age, and gender of each camp member. Each name was read aloud by the interviewer, and then the respondent was asked if he knew the person. If he said, yes, I know this person, then they were asked, is this person your friend, your acquaintance, or someone you don't get along with? So we have negative ties as well as positive ties, but for this talk, we're just looking at friends. We also have the closest friends network. So each respondent was then asked to identify from among their friends who were their 3 closest friends in the camp. And for each of the 2 closest friends, they were asked a series of questions to get at norms around HIV testing. So descriptive norms was for each of the 2 friends, they were asked this series. Do you think that this friend has ever had an HIV test? For injunctive norms, do you think friend 1 thinks that he should have an HIV test? And then, has friend ever encouraged you to get an HIV test? So sort of like advertising or giving advice to, that person had given advice to you. Here's some descriptive statistics for the baseline sample. 52% of men had ever tested at baseline. So as you can see, there's still a long way to go, even among our sample of men. Given that there's a generalized epidemic in Tanzania that 52% had ever tested is a serious concern. And so this study is really trying to look at why are they not testing and what could get them to test. Most of them were not in school. They were an average of 26, they were 27 years old. And this socioeconomic status is really within the group, so most of them were low, although we use some metric to classify them as low, middle, and high. And about a quarter of them had ever been married, 38% had ever had children. One thing I just wanted to tell you was that we did find that, well, we had pretty good retention rates. 78% completed wave 2, 82% completed wave 3. And then we found, using an intent to treat approach, that men in the intervention condition reported greater levels of HIV testing than men in the control condition. However, for this talk, we're not going to talk about the intervention effects. We're just looking at whether social norms changed HIV testing over the life of the intervention. So we want to assess, again, whether changes in social norms for HIV testing influence men to test over the life of the intervention, and then which of those norms that I mentioned, descriptive, injunctive, or advertising, which one were the most important for HIV testing. So just to give you some network descriptive stats, these are the densities, reciprocities, transitivities, and assortativities over each wave of data collection. And these are fairly similar across waves, which is good. It means that we can use the data in a longitudinal study. And also HIV testing assortativity was not too high, which was also good in the sense that we could actually measure social influence. It wasn't that people were just picking friends based on their HIV testing status. But here's one illustration of a camp that had high HIV testing assortativity at wave 1, just so you can see what one of them looked like. So then we used stochastic actor-oriented models to estimate social influence on HIV testing from wave 2 to wave 3. And Brian used RCNA to parse out whether the association between an individual's behavior and his friend's behavior was either due to selection, that people like to be friends with those who are like them, who have the same HIV testing behavior, or social influence, or some other endogenous factor. So there's a number of different ways that we measure norms. And first of all, we looked at EGO's reports of their close friends' alters. So we had alter tested, which is on average, does EGO think that his 2 close friends were tested, descriptive norms. Alter should, on average, does EGO think his close friends' alters should think EGO should be tested, and alter advertised, on average, does EGO report that alters encourage EGO to get tested. We coded this as 0 was neither friend had done it, 0.5 was half their friends, and 1 was both their friends. And then because we have the self-reported data both from the men and their alters, we can also look at their testing similarity at wave 2. So whether their friend tested and they tested, or if it was different. So this just shows you the correlations between whether the EGO believed that their alter tested and whether their alter actually tested. And you can see the correlations are kind of low. So normative views definitely can differ from reality. And actually, Marta Malawas published a paper on this, just looking at perceptions of HIV testing and how people who didn't test were more biased in terms of thinking that their friends had not tested. So the idea is that actually getting men to talk about testing might actually help them test more if they could correctly perceive their friends' testing. We also looked at whether alters reported the EGOs behave, like whether EGOs who nominated alters who nominated EGOs at their descriptive norms. So on average, do alters who nominated EGO as a close friend think EGO HIV tested, and so on. And then we also have this interesting data set that we can look at camp level norms. So we can look at the social network as a whole. So it's a little bit of a higher level than the closest friends network. So we have camp test rate, so what proportion of people in a camp were actually tested in the past 12 months. And then by aggregating the EGO level data, we can look at, on average, do people in a camp think that their friends were tested? What proportion of people in the camp think their alters think they should be tested? And what proportion of people in a camp said their alters encouraged them to test? Here's what some of the variables look like in terms of the distribution of the values. And of course, we're very interested in whether these camp level norms are actually correlated with the alter level norms, because you would think that they would be, right? Because you have these closest friends, they're within a network, and then they're probably correlated with the network level data. But as you can see in this correlation table and the box kind of in the lower right-hand corner, the correlations were not that high between alter level norms and camp level norms. We're still concerned about it, and you'll see that in the models. So the Siena model really involves fitting 2 different parts. First, you fit the selection side of the model such that simulations of the network data produce friendship networks that closely match the observed network data in each following wave. You then make sure that that model converges to a set of consistent parameter estimates, and then you estimate goodness of fit statistics to make sure that that model actually fits your true data. You then can estimate the behavior side of the model with a series of increasingly complex models. And the friendship network, what you get is really kind of like a logistical regression of tie prediction. So whether these values, whether these variables meet, the dependent variable is the odds of whether a person will nominate another person as a friend. And then the behavioral data, it's kind of just like a standard fixed effects framework where you can look at what factors influence change in reported behavior. So now I'm going to show you the results of these 2 different parts of the model. And I should note that this is only with 40 camps, so this was not with the full camp data set because we have some limitations around the data that I can talk about if you have questions. But we wanted to look at those that had a Jacquard index of greater than 0.15 and those that had not too much change in HIV testing over time. So this is just the friendship selection side, and you can see the blue bars mean that or kind of bluish gray bars mean that it was significant, and the red mean that it's not. So things that you would expect would influence friendship selection actually did influence friendship selection. So one variable up here is F friendship. It's whether or not you nominated someone at wave 2. Were they part of your friend network at wave 2? You were then more likely to nominate them at wave 3 as part of your closest friends. Popularity and out degree were also associated. Transitivity was associated with nominating someone as a friend. Same sex, so people were more likely to nominate those of the same sex. But as you can see at the bottom, whether they were similar on HIV testing, the dependent variable similarity, and the alter dependent variable similarity was not significant. So that makes us think that people were not just picking their friends based on their HIV testing behavior. We then looked at some goodness of fit statistics, so how well do these simulations reflect true trends in the data, and these were run across camps individually. And we found that, so this is just one camp showing the in-degree distribution, and the red dot shows how many people said that they had no friends, and it's a cumulative in-degree distribution. And the violin plots show the distribution of the simulations. And so the fact that the red dots are kind of within those violin plots mean that our data, our simulations are conforming well to our data based on the model that we built. And that's true also for the out-degree distribution. You can see the red dots are within the violin plots there as well, and for the geodesic distribution. So we feel pretty confident that our simulations and our model are performing well. Then on the behavioral side, we looked at a number of control variables. So these are just the ones that we included in all the models. So it was sex of the person, whether they had ever tested, and you can see again that those are significant. So whether they had ever tested was significantly associated with whether they tested in the past 12 months for HIV. And then, but out degree was not significant in this part of the model, how many partners they had had sex with in the past year, whether they were a camp health leader, which was part of the intervention, and their age were not significantly associated with testing in the past 12 months. Then we ran a number of models looking at the different types of norms. And so this is the social influence side of the model. And you can see up here which ones were significant, and you can see that should test is the injunctive norms. At the ego level, the camp level, and the alter level were all significant. So whether ego reported that their alter thought that they should HIV test was significant, and also camp advertised was significant. So the kind of cumulative perception about whether the camp level, overall camp sentiment about whether alters think that people should be tested was also significant. So we kind of have a friendship-based normative effect, and then we also have somewhat of an expectancy effect, whether alters think that they should be tested. But here, these were just estimates across the different models, so including the different norms in separate models. We then tried to put these together in the same model where we added camp level and alter level and the same model. So to try to see whether camp was more important than closest friends. All of these variables, unfortunately, were insignificant, but they had similar effect sizes to the other models. So we think it may be a power issue that if we had potentially more camps, that we could maybe see some significance here. But it was reassuring that they were all kind of in the same range in terms of the effect size. And so still injunctive norms seemed to be the most important effect, as well as camp level encouragement of HIV testing. And so our next steps are just to try to gain more statistical power with these models. These are small networks over multiple waves, so we have some issues here that we're dealing with. We'd love to hear your feedback if anyone has any thoughts about how to deal with that. And I'd just like to acknowledge this fellowship for supporting me, and as well as Brian, and this opportunity to work together, as well as Jim and Marta Malawa and Suzanne Maman, who's the PI of the intervention trial, who've all been incredibly supportive of this work. And we are excited to use these data because we have longitudinal waves, and look forward to presenting more and doing more with it. So thank you.
Questions or thoughts for you?
Yeah. Hey.
This is very fascinating. I don't know anything about this sort of literature, but I'm wondering if sort of the closed network is sort of normative in sort of the have sex with men in sub-Saharan Africa context, or if this is sort of an exception, and how you might think about this work if the networks were not closed networks.
Okay, so first of all, I should clarify that it's not men who have sex with men, it's actually heterosexual men. And in sub-Saharan Africa, transmission mostly occurs through heterosexual sex. And these men, so you have to know a little bit about the camps. I mean, they treat them like family. They talk about them. So I'm a qualitative researcher as well. I've done a lot of extensive qualitative work in the camps, and they talk about them as family. So even though we're looking at this closed network, which is a camp, and we're not looking at outside social influence, we know that this network is super important for them. They come there every day. They say, like, my camp members are like my brothers. You know, they help each other, and they support each other. So we feel pretty confident it's an important source of social influence for the men. And they've talked about it qualitatively as well in terms of HIV testing. Yeah.
A couple questions on the loan side. So who is the implementing partner? And then do they do it in groups? So maybe you have some variation in social networks that are influenced by the loans. Force new groups, and then you could actually get a causal estimate of these peer effects as opposed to, I don't know if you.
Yeah, that's a great question. So we had about 26% uptake of the loans among the intervention participants. All 700 were offered loans. So we've done a lot of work to try to figure out what happened, and we extended the loan uptake period. We offered mentoring. They had business training. There was a lot of incentivizing, but I think it didn't work in essence. And maybe, so I think because it was such a small proportion, I haven't really thought about it as a significant change in the networks, as a significant component of that, but that's a thought. I mean, we could look into that. And I should say also that the trial was non-efficacious for reducing STIs and reducing intimate partner violence. So it changed attitudes towards intimate partner violence, and it changed HIV testing. So that's why we kind of focused on HIV testing for this particular work, but it was disappointing that the end-line outcomes. So Muhimbili National Hospital, which is the National Hospital and School of Public Health, and then we had a microfinance NGO that's worked there for many, many years, Yosefo, Yeah, it's a lot going on in this trial. So thank you for your questions. I appreciate the opportunity.